Welcome to today's FERNE learning session on brain biomarkers and the evaluation of ED patients with mild traumatic brain injury. What is the pathology? What is the clinical benefit of this diagnostic test? And what role does this lab have in 2026? My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine, U of I in Chicago. I'm also Medical Director of the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This is the QR code for my information, and I want to thank the people from the Emergencies in Medicine Educational Group who helped provide this original presentation. I have no financial conflicts. I'm FERNE President and Board Chair. You can join us at ferne.org or on social media. And at YouTube, you can join us at FERNE.org, where we have several different playlists, shorts, and longer presentations. This information is available to you using this QR code, and there is extended information including a policy brief, clinical update, and mild traumatic brain injury patient information using this QR code. So the next process will be to examine some specific issues related to the clinical use. What are the confounding factors, effectiveness factors, cost and reimbursement issues, and clinical adoption issues? The first thing we'll consider is confounding clinical factors. So what are some confounding clinical factors? We note that older patients, those with reduced renal function, and those with alcohol use may have a greater number of false positives, reducing specificity. However, we recall that the role of this is as a rule out the need for a non-contrast CT, and if specificity is greater, as long as sensitivity and negative predictive value remain high, these lab biomarker tests still have value. So let's look more closely at older age. We know that as age increases beyond 65 and 70 years, the threshold for considering the test to be positive needs to be 50% to 100% increased. In other words, the values of these two brain biomarkers will tend to creep higher with advancing age, such that in order to have a cutoff that is considered negative, you can raise the cutoff value. Oppositely, in order to consider the test to be positive, there are higher cutoffs in older patients. Similarly, in patients with renal failure whose creatinine is greater or equal to 2, cutoff modification is warranted. The general cutoff for being positive is doubled because we understand that with renal failure, patients will have a higher baseline value of GFAP and UCH-L1. Again, when using this test to detect what is a positive result, the sensitivity is still high, as is negative predictive value. So, how does the cutoff for a positive lab test change with alcohol use? In patients who are acutely intoxicated, as was seen with patients with renal failure, the cutoff for being positive doubles. That is to say, in the presence of alcohol intoxication, these values of GFAP and UCH-L1 may be higher, and it does not necessarily signify the presence of a lesion on non-contrast CT. Remember again that sensitivity and negative predictive value should remain the same, allowing this test to be useful to rule out the need for non-contrast CT when the lab test is negative. So again, let's talk about, in summary, cutoff adjustment and the presence of confounders. Lower specificity in patients with these confounders, increased age, renal failure, alcohol intoxication, means there may be more false positives and more non-contrast CTs performed than what might consider to be optimal. But when we know that reduced specificity decreases the clinical efficiency of these brain biomarkers, we still know that these biomarkers remain safe as rule-out tools, even though they lose some operational value because non-contrast CT reduction may not be as robust in these three groups: older age, renal failure, and the presence of alcohol intoxication. So let's talk about clinical effectiveness. What is the clinical effectiveness? When considering clinical effectiveness, you need to consider the cost of the tests. We need to understand that there is liberal CT use in patients who have a GCS of 13 to 14 because their GCS is not normal at 15. We know that there are multiple factors that support CT use. It's quick, effective, answers a question, allows disposition to the lowest level of care possible. We know that there are generally a limited number of what are considered to be low-risk mTBI patients that require neuroimaging, and we know that there is significant anticoagulant use in patients who are older and sustain mild traumatic brain injury. Let's talk a little bit more about that anticoagulation. So, we know that in anticoagulated atrial fibrillation, there will be a 10 to 20% shrinkage in negative predictive value, even though there's a high sensitivity. In other words, anticoagulation itself is a high-risk modifier, and patients who are anticoagulated generally will not be considered to be low risk. And in this patient population, these lab brain biomarkers may not be as broadly used. What about cost and reimbursement? There's a cost-benefit calculation that occurs, and it has to do with the cost of the lab testing versus non-contrast CT. These assay prices are generally $75 to $200, and CT testing is generally $300 to $800, such that the non-contrast CT cost is approximately 4 times higher. Optimal use of these lab tests occurs when you can defer 20% or more in eligible cohorts of mild traumatic brain injury patients who are considered low risk. So at the highest costs, if you do 10 assays, it's $2,000, and if you do 10 non-contrast CTs, it's $8,000. Combining those is about a $10,000 total cost. If you do 20% fewer non-contrast CTs, the 12 assays then will have cost you $2,400, and the 8 non-contrast CTs will cost about $6,400, such that the total cost with a 20% non-contrast CT reduction is $8,800, or a $1,200 less total cost on a basis of $10,000. In other words, with reimbursement assumed, you can assume about a 12% reduction in cost over patient populations in whom there's a 20% decrease in the use of non-contrast CT. So what are the reimbursement opportunities related to the use of mild TBI patient biomarker use? Commercial payer policies do differ, and as of late 2025, some Blue Cross Blue Shield organizations still were labeling mild TBI biomarker use investigational, subject to restrictions and limiting reimbursement. When looking at the Abbott iStat TBI plasma platform, CMS now appears to recognize a specific code for GFAP UCHL1 testing, this code 0570U. And the test appears to be covered under Medicare when ordered for the FDA cleared indications, that is, rule out of intracranial lesions in mild TBI and avoiding the use of non-contrast CT. Note that payment rates do vary by region and Medicare administrative contractor. What about reimbursement opportunities with the Banyan Brain Trauma Indicator system? Again, as with the Abbott system, there's now a specific biomarker code 0570U, and reimbursement can occur when used in EDs for suspected mild TBI injury within 12 hours of the injury itself. So what about the clinical adoption issues related to the use of these lab tests? As of late 2025, the clinical adoption of these brain biomarker lab tests in U.S. emergency department was estimated to be less than 10% of all EDs nationwide. It is noted that the uptake appears to be strongest in academic centers and large trauma hospitals, especially those who participated in the validation studies for these lab tests, or in those who are attempting using a best care protocol to find some precision medicine initiatives for improving outcomes and reducing healthcare costs. In general, most community emergency departments still are relying on CT imaging in patients with mild traumatic brain injury when the patient is considered to be not a low-risk patient. So, what other factors can enhance the clinical adoption of these mTBI biomarkers? Guideline endorsement by relevant organizations would improve understanding and adoption by clinicians. Workflow integration strategies using point-of-care use or facilitation with the EMR will improve adoption. Reimbursement enhancement, especially consistent coverage and the avoidance of describing these lab tests as investigational, will improve adoption. Expanded clinical evidence always enhances adoption, especially when there's real-world validation that demonstrates cost savings. Improved clinical awareness and education through CME programs and clinical support tools will be helpful. Increased marketing momentum will support use of these lab tests. And lastly, increased awareness through public safety and health messaging will allow radiation to be reduced through the decreased use of non-contrast CT, which also will reduce healthcare costs. So, what guidelines support the clinical adoption of mTBI biomarkers? Currently, no U.S. National Society guidelines currently mandate biomarker use to reduce the number of non-contrast neuroimages being performed. Recommendations generally frame GFAP and UCH-L1 as adjunct to clinical decision rules. And the ACEP 2023 guideline provided a level A recommendation that says, use the Canadian CT head rule to guide CT utilization. Also of interest with regard to clinical guidelines are the University of Michigan clinical protocols that have been published. They are detailed and they operationalize the use of brain biomarker use when considering neuroimaging in mild TBI patients. This institutional guideline supports CT avoidance when both biomarkers are below the cutoffs in appropriate mTBI patients. For more information, go to FERNE.org where you can find content relevant to your clinical practice. We're also available on social media and on YouTube at FERNE.org. You can find playlists and video content that will improve your patient care, patient outcomes, and your clinical practice. So with that, I'd like to thank you. And if you have any questions, you can email me at my email below. And always go to FERNE.org for finding more information regarding how these tests and other strategies for providing optimal patient care will improve patient outcomes and allow for us to optimally utilize our limited healthcare resources. Thank you again for participating in this educational program.